Hello, podcast listeners. Welcome to the next installment of the Neurocritical Care Society podcast. My name is Joshua Levine. Today I'll be speaking with Dr. Deena Nasr from the Mayo Clinic in Rochester, Minnesota, about her paper in Neurocritical Care entitled Acute Brain Diseases as Triggers for Stress Cardiomyopathy, Clinical Characteristics and Outcomes. This is a retrospective observational study of 34 consecutive patients admitted to a single center's neuro-ICU that aimed to describe the cohort clinically and to find features associated with functional outcome. Welcome to the show, Dr. Nasr.
Thank you so much for having me.
Before we dive into your paper, please tell us a bit about yourself and why you decided to study stress cardiomyopathy.
I am a cerebrovascular neurologist, and my interest in the topic of stress cardiomyopathy really stems from some of the exposure that I've had during my clinical training. I was first exposed to it back in med school with a patient who had stress cardiomyopathy after learning of her husband's death, and again in residency on the neurologic intensive care unit in patients with subarachnoid hemorrhage. And then finally in my cerebrovascular fellowship in a patient with a right insular stroke. So there's always been a very clear heart-brain connection, but not entirely understood, which makes it a very mysterious disease. And so my interest in researching it and putting out this publication is really to help bring light to the multiple neurogenic inciting events experienced at our institution and their clinical course in association with stress cardiomyopathy.
For the trainees in the audience, please provide some background on stress cardiomyopathy. Who gets it, and what's our current understanding about the underlying pathology?
Stress cardiomyopathy is basically a reversible ventricular dysfunction that it primarily occurs in the apex of the heart. And it was initially described in the setting of severe psychological or emotional stressors. Over the last several decades, it's been also described in the setting of neurogenic physiological stressors, particularly subarachnoid hemorrhage, which really, puts into question whether a neurogenic stress cardiomyopathy versus more traditional stress cardiomyopathy represent the same disease entities. It goes by a lot of names: Takotsubo's cardiomyopathy, based off the Japanese octopus trap jar, looking similar to the cardiac dysfunction occurring in the apex. Goes by stunned myocardium, broken heart syndrome, which again alludes to the initial psychological inciting events that were initially described with this disease phenomenon. As far as the pathogenesis, we don't really know. Proposed mechanisms are multivessel coronary spasm or microvascular dysfunction, which really there hasn't been much proof in the literature to validate these. And the most common and a recognized hypothesis is the catecholamine hypothesis. And basically the idea is that there is some sort of inciting event, eventually leading to cardiac dysfunction, such as arrhythmias and myocardial damage.
Yeah, and I'd like to point out that the pathology of stress cardiomyopathy is distinct from myocardial infarction. In MI, you see coagulative necrosis, whereas in stress cardiomyopathy, you see contraction band necrosis, where the cardiac myocytes die in a contracted state. What also strikes me is that when you read the literature, it seems like the purported mechanism of injury, catecholamine toxicity, is still regarded as a hypothesis, but it seems like there's very cogent support for the idea that catecholamines are the causative mechanism. Is that your understanding too?
Correct, I agree. And the idea behind the myocardial contraction band necrosis is that the pathology has been seen with subarachnoid hemorrhages, suffering cardiac injury, seizures that have led patients to have sudden death, and the area of myocardial injuries is not necessarily in a particular vascular distribution that would suggest ischemia as well. So I agree with you. There's a lot of indirect evidence that points towards the catecholamine hypothesis.
And that's one of the things I tell my fellows, that with stress cardiomyopathy, the EKG and echoes show injury patterns that typically do not fit a vascular distribution as they would with MI. Now let's move on to your paper. Can you describe for our listeners the purpose for conducting your study and the methods you chose for it?
Sure. So the basic idea behind the study is really just to describe the clinical course of multiple neurogenic inciting events causing stress cardiomyopathy. So it was more of a description or an observational study. My hopes were to try to find differences in clinical presentation, but also find different variables that might predict functional outcomes in this particular group of patients.
I think your paper brought up a number of important points about neurogenic stress cardiomyopathy. First, that it can occur in many types of acute neurologic illnesses and not just aneurysmal subarachnoid hemorrhage, which is the most common association people have with it in neurocritical care. In fact, the worst case of stress cardiomyopathy I ever witnessed was in a patient with a ruptured cerebellar AVM. Second, the pattern is not always apical ballooning as described by the classic octopus pot or Takasubo morphology. And third, the percentage of men affected by cardiomyopathy due to a neurological insult is higher than the percentage of men affected by cardiomyopathy due to an emotional trigger. Is that correct?
Correct. So I would say that in both neurogenic stress cardiomyopathy and the traditional stress cardiomyopathy, the predominant gender is still female, but there is a larger proportion of males, definitely. In the prior studies on traditional stress cardiomyopathy, the proportions are roughly about 10% males and 90% females, whereas in our cohort it was 2/3 females and about 1/3 males. And this has been described in multiple other large case series as well. The other thing that was interesting is that these patients presented more with symptoms of heart failure. So in our cohort, dyspnea was primary symptom that patients presented with, and the least common symptom was chest pain as compared to traditional stress cardiomyopathy where chest pain is the most common symptom. And I suspect some of these variations are due to, as you alluded to, the actual etiology or the inciting event. Neurologic patients with intracranial hemorrhage from subarachnoid or AVM, for example, are going to have altered awareness or alertness or potentially language dysfunction, which might make it difficult for them to report things like pain.
It seems to me that in the cardiology literature, the disorder is referred to as apical ballooning syndrome or Takasubo cardiomyopathy, whereas in the neurology literature, it's called neurogenic stress cardiomyopathy or stun myocardium, and there's a tendency in publications to separate them as possibly different diseases. But regardless of the underlying cause, at its most basic level, the final common pathway is a surge of catecholamines. Is it possible that they are all one and the same disease and that the differences in epidemiology and clinical characteristics are due to the specifics of the trigger and the population affected by this specific trigger and not that they're separate diseases?
Exactly. I think the underlying pathogenesis and the disease itself is the same. And the differences that we're noting in their clinical presentation is really just due to what the trigger might have been. But it's important to know all the different variations in clinical presentations, whether it be symptoms or testing, so that we're able to really recognize this disease early on.
Now let's talk a little about outcome. I found it interesting that you observed poor outcomes in patients with more severe cardiac dysfunction, such as those with greater right ventricular failure, but you did not see an association between poor outcomes and worse Nader Glasgow Coma Scale scores. Can you comment on this?
I agree with you completely. I was surprised, and I suspect some of it might have to do with our small patient size or sample. So the GCS or the Glasgow Coma Scale and the Apache 3 score did have kind of a borderline trend towards significance. And I think because of the small patient size, we're going to have a lower detection for mild or moderate association when we're predicting functional outcome between groups. So I suspect there's just a limitation of the study because of just the sample size and statistical analysis rather than a true observation. I think looking at the fact that RV dysfunction or right ventricular dysfunction and inotropes were both associated with poor outcome, that those represent more of a marker of severe cardiac injury I would suspect that in the setting of a low ejection fraction, it would be the same, although it's hard with retrospective studies to really know why this wasn't associated. It would have been nice to do more of a multivariate analysis to see more independent prognostic variables of poor functional outcome. But again, because of the small sample size, we weren't really able to perform further statistical analysis like this.
What were some of the challenges you encountered in doing this project?
I have to say it was a bit difficult. There were quite a few limitations, some inherent limitations just because it's a retrospective study, and so we're very dependent on chart documentation, which opens us up to a lot of biases. For example, when trying to accrue patients, we had 34 patients, and about a little less than half of them we defined as probable stress cardiomyopathy because we did not have any echocardiogram or angiographic proof of reversal, but they presented very similarly to the definite group. We try to account for things like this in this case, we compared the two groups and we found really no major differences between them, and so we pooled the two groups for statistical analysis. But that was definitely one limitation. Other things would be, and we tried as much as possible to keep things strict, but clinical biases or diagnoses just based off the physician's care. And we tried to stick to strict definitions of stress cardiomyopathy. So we used a modified Mayo Clinic criteria for those patients. We stuck to a strict definition of sepsis. And really to try to eliminate selection bias in patients who have coronary artery disease, we excluded any patient that had a history of coronary artery disease or did not have an angiogram to prove that there was no occlusive disease. So we tried our best to account for a lot of these limitations, but they're certainly there. And we already talked about how the small sample size made statistical analysis a little challenging.
Yeah, this type of research can be quite challenging and is very time-consuming, but can contribute a lot to our understanding of diseases, especially uncommon ones that are difficult to study prospectively, especially in randomized trials. What do you think are the most important unanswered questions when it comes to stress cardiomyopathy?
I think we're still learning really what the differences are, and it's an ongoing debate regarding whether neurogenic stress cardiomyopathy or traditional or apical ballooning syndrome are one and the same. And so I think that's something that would need to really be addressed with more head-to-head studies in order to answer that question. So at least in the literature, in my review of the literature, there is a number of other large or small case series that try to look at that, with the most recent one being published last year, titled Takotsubo's Stress Cardiomyopathy versus Neurogenic Stress Cardiomyopathy, similar albeit different, for example. And they really try to highlight major differences between neurogenic stress cardiomyopathy and Takotsubo. For example, neurogenic stress cardiomyopathy patients didn't have ST elevations. All their echocardiogram findings were atypical non-apical variants. 21% only involved the apex, as compared to our study, which was probably more consistent with traditional Takotsubo's, where 44% of the patients had ST elevations, where the majority of our patients had apical ballooning. So there are some discrepancies there. I suspect, again, it's likely due to the neurogenic inciting events. In that paper I just discussed, most of their neurologic patients were subarachnoid hemorrhages, and in the literature, the vast etiology that's been cited and described has been in the setting of subarachnoid hemorrhage. So I think we need a larger study, something multi-center, given how rare the disease is, that can accrue enough patients to detect a lot of these differences or similarities between the two groups, which might give us a better idea as to whether they're one and the same. Obviously, a prospective study is ideal, but I think enrollment would be very difficult, and there would be a lot of issues with cost effectiveness. So there'd be a lot of hurdles, but that would really be the more ideal way to answer some of these questions.
Absolutely. I think that this disease needs better characterization. When we see it in the neuro ICU, it is often mild and treatable, but occasionally it's not. And then we're left with questions about optimal management. For example, most of our vasopressors are catecholamines, which could potentially worsen the stress cardiomyopathy. Should we try to avoid catecholamine vasopressors? And how do we optimize long-term outcomes? The literature perhaps suggests that ACE inhibitors may improve long-term survival, but surprisingly, beta blockers don't.
And the proposed remodeling benefits of beta blockers as well. I agree with you, yeah.
So I think there's a lot we have to learn about this, and I think your study has contributed to our knowledge base. To wrap up the show this week, could you summarize for the listeners what they should take away from reading your study?
I think it's, as you mentioned, important because it's descriptive in that it looks at a diversity of neurogenic inciting events. In our cohort, 2/3 of our patients had different neurological diseases rather than subarachnoid hemorrhages. I think it's important in that it shows some of the variations in clinical presentation as compared to the traditional stress cardiomyopathy that we're used to, so that we're able to identify this disease early on. Patients in neurogenic stress cardiomyopathy will likely present with heart failure, that the most common EKG changes in my cohort as well as other published series is QT prolongation. And potentially in the future, as you alluded to, maybe even prevention or treatment. What's important here is that only two variables that were associated with poor functional outcome were inotropic support and right ventricular involvement, which really suggests that it represents more of a severe form neurogenic stress cardiomyopathy in my patient cohort, which might actually explain why my patients our patients didn't have good outcomes at discharge, although there was significantly good outcomes at follow-up in 5 months, with essentially half of those patients having no deficits. Overall, I think the observational components are important to look at, as it's not really been something that's well described in the literature.
Dr. Nasr, thank you for talking with us today.
Thank you for inviting me.
Again, that was Dr. Deena Nasr from the Mayo Clinic in Rochester, Minnesota. This podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. The Neurocritical Care Society provides and advocates for the highest quality care for patients with critical neurological illness throughout the world. Follow us on Twitter @Neurocritical, on Facebook, or visit www.neurocriticalcare.org for more information about NCS and the comprehensive resource that it offers. This is Joshua Levine, and on behalf of the Neurocritical Care Society, thanks for listening.